Signatera Residual Disease Test is a personalized, tumor-informed ctDNA assay that detects molecular residual disease with high sensitivity and specificity. Built using the patient's primary tumor, Signatera offers real-time risk assessment, treatment response monitoring, and detects disease recurrence earlier than standard of care tools. Backed by more than 100 peer-reviewed articles, Signatera is changing how cancer is managed. Learn more at natera.com/oncology.
Welcome to the AUANews Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Welcome to AUA News Inside Tract. I'm Kyle Richards, urologic oncologist at the University of Wisconsin. I'm also chair of the Urology Care Foundation's Technology and Publications Committee. I also serve as the AUA RUC member, and it's great to be here this morning with to co-host or co-guest this podcast with Dr. Marchetti. So I'll turn it over to her.
Hello, everyone. Yes, this is Kathryn Marchetti. I'm a urologic oncologist at the University of Iowa. Really excited for this conversation about a rapidly changing field that's increasing the options that we have as providers for our patients.
Yeah, and as you may or may not know, November is Bladder Health Month. So in this episode, we're diving into the latest developments in bladder cancer, as Katie mentioned, a field that's undergoing really rapid transformation. So let's go ahead and dive on in. We're going to focus mostly on the non-muscle invasive bladder cancer space today. There is a fair amount of excitement and change that's happened in the advanced space as well as the muscle invasive space. And Dr. Marchetti and I were sort of talking about how we wanted to sort of organize our session, and we thought it would be useful to sort of do it by risk categories. As many of you know, that there are risk categories within the non-muscle invasive bladder cancer space, and I was going to start off with we'll kind of go low, intermediate, and high, and then there's also the BCG-unresponsive category. So there's been some developments in all of these spaces. I guess, Katie, in your mind, what's starting with the low risk space? What's going on in that space, and any changes in the low risk space?
From my perspective, for these low risk patients, most of the developments have been more in the intermediate and high risk group, which I think is particularly important considering these patients' risk of recurrence and progression. And so expanding those options for patients is kind of most of where the development that I've been focusing, kind of how I repeat my counseling and re-counsel patients.
Yeah, I totally agree. I think the low risk space, we're talking, low grade TA, non-muscle invasive bladder cancer, largely managed with TURBT, which has been really the standard for decades now. There's a new drug that was FDA approved for low grade intermediate risk. It's called ZUSDURI, which is a little bit of a mouthful, but essentially that's a mitomycin gel. Do you want to talk a little bit about that drug, Katie?
Yes, definitely. Yeah, so focusing on that intermediate risk group, it's a really heterogeneous group, as you had mentioned, with kind of that high risk of recurrence, 50 to 70%, and a low, thankfully, risk of progression. About 5% of these patients will progress to muscle invasive disease and beyond. And as you had mentioned, Dr. Richards, this includes patients with that PTA low grade, over 3 centimeters in size, multifocal recurrence within a year, as well as that PTA high grade, small, so less than 3 centimeters solitary. And this represents about a third of our non-muscle invasive cohort. So that ZUSDURI is a new development specifically for the intermediate risk group patients that have low grade disease. As you had said, this is a reverse thermal hydrogel of mitomycin. It's instilled into the bladder with a catheter and at body temperature solidifies. And so this creates a drug depot for patients that allows the mitomycin to be administered over a longer period of time. about 6 hours from what the manufacturer's estimate. And the great thing about this is that prolonged dwell time allows the medication to act on the tumor for a longer period of time and reduces the toxicity and the side effects for patients. So kind of best of both worlds. And this is an FDA approved therapy for use now, which is great.
Yeah, and I think the thought behind this drug is it's a chemoablation, which is a different sort of paradigm. The paradigm for many years has been you got to resect, you got to do TURBTs on everybody. I think what we have started to appreciate more so is the morbidity of TURBTs. It's, we consider it a, minor outpatient surgery, but then as we've started to do more patient-reported outcome studies, we've realized that patients undergo a lot of morbidity in the first month after TURBT. And this is an option to potentially mitigate that morbidity and do these treatments in the office. The pivotal study that was published showed in 82% of patients they remained free of disease at 12 months. Now, keep in mind, this was a highly controlled clinical trial. Many of the tumors were quite small. So we have to sort of keep that into context and sort of see how this will perform, in the real world, and make sure that you're selecting the right patients for this treatment. Patients that want to try to avoid going to the operating room, and patients that I think have small, low grade. I think is the key. This is not approved for patients with high grade disease.
Yes, definitely, definitely. In the Envision trial, as you were mentioning, of the urologists that were involved in the trial, they surveyed, they said that about 90% of the patients included would have otherwise had to undergo a TURBT and underwent this chemoablative therapy instead. So kind of speaking to what you were talking about earlier, it said it's saving a cohort of patients going to the OR, which although we kind of think of as an outpatient minor procedure, certainly have patients have brought up to me in clinic, also in the research side, how a TURBT is does in and of itself require a considerable amount of healing. And from the patient side of things, in a qualitative component of that Envision study, patients were really excited about having the non-surgical therapy available to them. And this is in a group of patients that they themselves had undergone multiple TURBTs. So it's nice to see that there's this new drug for this intermediate risk group of patients, has the chemoablative potential, as you were discussing, seems to be well tolerated, and fills this kind of patient identified gap in how we're caring for patients with good response.
Yeah, well said, Katie. I think moving on to other potential new options in the intermediate risk space, we do have, I know there are some ongoing clinical trials, so we don't have anything else that's FDA approved, that's new on the horizon, that's new. I know of at least two trials. There's one trial called the Pivot trial,
Yep.
which is sponsored through the SUO CTC. That is a trial that is using a drug, cretostigmine, which we'll talk about, I think, more on the BCG-unresponsive side, because that's there's some interesting data there. And then there's another trial called ABLE-32, which is using a drug called Adstiladrin, which we'll also talk about later. Have you do you have any at UW? We have had the Pivot trial opened. I know you just getting going at Iowa, but what are your thoughts on sort of these sort of novel therapies in the intermediate risk space?
Yeah, definitely, definitely. With how much new activity there is in the high risk space, it's nice to see that there's more attention on this group of patients. As you had mentioned, this Pivot 006 trial backed by the SUO, it seems to be enrolling really well, and so hopefully we should have some good data on the use of this cretostigmine in patients, which, as our listeners know, is this oncolytic adenovirus that replicates in and kills the cancer cells. And so it's administered in a familiar dosing schedule with the 6 upfront weekly installations, and then weekly for 3 weeks as kind of as we're familiar to. And this Pivot 006 is comparing this therapy to just surveillance. So it's really going to help us assess the true efficacy of this effect size of this therapy.
Yeah, both the Pivot trial and then Able 32, very actually very similar designs where they had an observation arm, so patients were randomized to the treatment or observation. And then in the observation arm, there's also a crossover component so that if patients did recur, they could cross over and receive the treatment. So it's nice, as you know, many of the BCG-unresponsive trials, there was no comparator arm. This will at least have a comparator arm to look at. And we'll see. Yeah, the Pivot trial just completed accrual. It actually fairly rapidly accrued. And this is a need because we do see a lot of patients that have these recurrent, low-grade tumors that are intermediate risk, and we don't really necessarily want to use BCG on them because of other concerns with BCG shortage. I think, which is a good segue to our high-risk population, which is, the standard of care for those folks is BCG, and we've been living in a world of BCG shortage for over a decade now, and it's intermittently been, problematic. So what are your strategies, Katie, for managing the BCG shortage, and what can people do to get through these times where we maybe don't have the access to BCG that we need?
Yeah, definitely, definitely. It was just actually earlier this week that we had another division email about the shortage and how we're managing it. And really, here at Iowa, what we're doing is aligning with the kind of recommendation statements from the AUA, the SUO, which, as we know, are backed by patient-led organizations as well, like Beacon. And so, for the intermediate risk group, making sure that we use intravesical alternatives to BCG, the chemotherapy options, and then progressing these patients after first-line chemo to some other chemos like Valdosi or quad chemo agents. And for our high-risk patients, we're conserving our BCG for high-risk patients with additional risk factors like CIS. We're giving full dose induction, splitting our maintenance courses. But really at Iowa, even for patients that are in the high risk group, we are starting a lot of these individuals out with gemdosi up front and then saving that BCG for the second line if they fail. What about you guys at Wisconsin?
Yeah, I would say similar strategies. We've been limiting maintenance up to 1 year as opposed to the 3 year, which was originally from the SWOG protocol. Similar to you considering induction with other agents, chemotherapy for sure. We've toyed with the idea of splitting the dose, half dose or third dose, and then you can treat multiple patients on the same day. However, it becomes logistically somewhat challenging because you got to have multiple patients kind of lined up on the same day. Which at a high volume institution, if you're treating a lot of patients, that's a little bit easier, but sometimes space constraints can be challenging. So yeah, that's mostly what we've been doing. There's also this, we've thought about, there's a recombinant BCG expanded access program that's sponsored by Immunity Bio. So we've toyed with the idea of getting access to this recombinant BCG. However, it does need some additional studying because it does not have FDA approval yet in the U.S. So that will be, something to consider, especially if you're at a place that really has limited or no access to BCG. And really, Iowa has been at the forefront of intravesical chemotherapy, which is great. And do you have most of the data that we have for intravesical chemotherapy in the BCG naive setting is more retrospective, and a lot of it's come out of Iowa. But what are your thoughts on the efficacy from the data that you've seen?
Yeah, yeah. So as you said, a lot of this data is retrospective, but is very promising and gives me a lot of comfort in offering this to patients as a first line, even in this high risk group. to say that this is an effective way for us to start, and we can pivot and use BCG if needed, but saving that therapy for patients that have either failed this, or patients with additional or significant risk factors. So the retrospective data that we have on the gemdosi shows that at 12 months, about 85% of this group had complete response. And again, this is retrospective data compared to comparing to efficacy of BCG, which was rated at about 71% of the patients. And the kind of from a tolerability standpoint, this data also suggests that BCG is maybe a little bit better tolerated, or that gemdosi is a little bit
Mm.
perhaps better tolerated than BCG, with less patients having to stop or discontinue therapy, which is kind of from a symptom standpoint, again, encouraging, and something that I definitely talk about when I'm counseling patients on this option.
Yeah, I've looked at that data closely over the years, and I agree. The efficacy looks really good. Tolerability in my practice has been quite favorable. Logistically, there's some patients that don't like it because you have to, it's a sequential treatment, so the patients have to spend a little bit extra time in the office. So sometimes if you have space issues, that can be a concern. But you have to be sometimes creative with scheduling and finding spaces within your institution to sort of manage this. I'll be curious to see what the results from the Bridge trial. The Bridge trial is as many people know, is a randomized phase 3 clinical trial that completed accrual in 2025, randomizing patients that were BCG naive to BCG versus gemdosi, and prospective. A lot of good patient-reported outcome data that will come out of that study. So I'll be very excited to see that. The results probably will start coming out in the next few years. And but for now, I think the data, at least the retrospective data, looks very solid. So if you don't have access to BCG, it's very reasonable to give gemdosi.
Mm-hmm. And kind of harking back to one of the points you made earlier, Dr. Richards, you're not alone in what you're saying about some kind of constraints of giving that gemdosi, considering the fact that it's two agents. About 40% of providers that were involved in giving gemdosi have said that there are some common barriers to administering it. But I think one of the great things about this therapy is cost, which we'll talk
Yeah.
about the cost of a lot of the other options we're going to be going over in a minute. But it's one of the more cost-effective options for patients. And so based upon its efficacy and retrospective studies, the familiar dosing schedule, cost, tolerability, I feel like are a really strong front runner in the setting of our BCG shortage.
And the maintenance, can you just touch on maintenance therapy for intravesical gemdosi?
Yeah. So here at Iowa, I had kind of I said familiar maintenance schedule. I appreciate you bringing this up. So the induction course is similar to BCG in that it's once a week for 6 weeks, but then the maintenance is once a month for kind of that getting people to that 12-year mark. So not exactly like our BCG maintenance.
So at least 1 year of maintenance is typical.
Yes.
Yeah. I think
Mhm.
the Bridge trial extended it to 2 years, so we'll see if there's, and they'll probably look at any changes from 1 to 2 years. But yeah, I think at least a year of maintenance has sort of been what we've been following as well.
Mhm.
Um, all right, well, let's. I think that's great. A lot of exciting things going on in the high risk space, and the other thing is, there may be better access to BCG coming up. We have the main manufacturer of BCG Tice strain in the U.S. is Merck, and there is news coming out that they're ready to ramp up their manufacturing probably in 2026. They built a new facility that will help to meet the demand. So I don't think BCG is going away. It becomes, once again, as you mentioned, a lower cost option and still highly effective. So it'll be interesting to see once their new facility opens if this BCG shortage hopefully will be remedied.
Definitely. And opening this new facility, as you mentioned, is anticipated to triple the amount of triple their production. So But again, it's nice to have a lot of tools in the tool belt, especially in this group of patients that has a high risk of recurrence.
And speaking of which, good segue to I think our final segment, which is, when patients are no longer responding to BCG, right? This is a population, maybe, 20 to 40% or somewhere in that range of patients will not have a good response to BCG. They'll develop what we call BCG-unresponsive disease. And these are patients that we worry about, right? Because they can, sometimes they can progress, meaning their cancer can worsen. They can also have a lot of, recurrences and TURBTs and frequent biopsies, which, as we talked about earlier, poses some morbidity. So there's been a lot of movement in this space with new drug therapy. But where does, sort of, with all this new movement with new drug therapy, where does, in your mind, Katie, does cystectomy fall in?
It's definitely come up a lot more since the news of Deion Sanders has broke about this as an option for patients with in certain patients with non-muscle invasive disease, and has kind of shed light on this area in an unexpected and interesting way. It's nice to have some data from the cysto study to be able to counsel patients on
Yep.
kind of what their health related quality of life outcomes as well as clinical outcomes will be. Certainly saving it in my practice for very specific sets of patients with high grade T1, CIS, kind of LVI, or kind of some other variant histology, things like that. And particularly those patients that aren't willing to take the risk of recurrence or progression on some of the therapies that we have talked about or are going to talk about. What about you, Dr. Richard?
Yeah, I mean, it's a discussion. It's definitely something that I feel like, if you have a patient that's not responding to BCG or, even, other intravesical agents, it needs to be discussed. And Coach Prime, I think, brought, a lot of good attention to bladder cancer and also to neobladders, which I think, he had in his press conference, let the world know he had his bladder removed and had a neobladder. So hopefully we can raise awareness for continent diversions as well, and obviously properly selected patients. And but sometimes you start talking to a patient about removing their bladder, and this just happened to me yesterday in clinic for a patient that was kind of developing BCG unresponsive disease, and it becomes a much more, she immediately started, getting emotional about it. I mean, this is a big deal for many patients, and so it's good that we have some new options because prior to, the last few years, we really only had one FDA-approved drug for BCG unresponsive carcinoma in situ of the bladder, and that was valrubicin, right? So that was the only drug that was FDA approved for about 20 years. So let's kind of get into some of these new therapies and sort of break them down so people can kind of understand what they do and how they're administered and sort of some of the nuances. Some of this stuff we're still learning, like because a lot of this stuff is sort of hot off the press. Really the first intravesical drug that was FDA approved for BCG unresponsive. Keep in mind, this is carcinoma in situ, so that's kind of a big component of this. Is a drug called Adstiladrin or nadofaragene. The nice part about this drug, in my mind, is it's the easiest drug to administer in the sense that it's given once every 3 months. So in a year, a patient only needs to come in 4 times for an installation. But what are your thoughts on Adstiladrin, Dr. Marchetti?
Yeah. So as you know, this is a non-replicating adenovirus vector-based gene therapy for patients in that BCG unresponsive non-muscle invasive space with the CIS. And it, as you said, it's the dosing schedule is different than what we're used to. Thankfully, the toxicity profile seems to be pretty good. With in the trials studying it, only about 4% of patients had grade 3 or higher toxicity, with urgency being the most common of those. At 12 months, it seems that there's about a 24% complete response in the group that studied, and about a quarter of the patients in the trial were able to actually get those 4 or more treatments that were included. As you said, it's dosed every 3 months. 4 doses were given in the trial. The only thing with this is kind of thinking about the cost of this drug. So about $60K per dose. What are your thoughts on this?
Yeah, I think it's a lot of these novel therapies, there's R&D costs that have to be recouped because of the expense of conducting the clinical trials and the drug development and the marketing. So it is it's a concern, and we'll see this, I think, with the other agents as well. So I think the positive with the drug is the ease of administration, as I mentioned. Also, I do think that we have the longest follow-up data with ZUSDURI. They've actually published recently some 5-year data showing that 43% cystectomy-free survival at 5 years. So the vast majority, about 50% or so are saving their bladders with this treatment. So that's reassuring to see. I personally would like to see that number even a little bit higher. So, and then if you look at the recurrence free survival at 57 months in the CIS group, it's down to 13%. So, the question with a lot of these drugs is, are you just sort of kicking the can down the road, and then are you just going to sequence it with other agents because these patients, the vast majority, are destined to recur? That, I think, is a concern. I think the next drug to market, the intravesical, is a drug called Anktiva. Anktiva is an IL-15 superagonist. This was FDA approved this past year, I believe 2024 or early 2025, and it is given like BCG, right? It's like similar to the BCG schedule. In fact, it has to be given with BCG, right?
Yes, it does. Yes.
So what are your thoughts on Anktiva, Katie?
Yeah, so this therapy activates the body's natural killer and killer T cells to attack the tumor cells. And it's, as you said, given with BCG. It's been studied in the Quilt 3032 study. That trial had 107 patients, and a lot of multiple arms were studied, but we'll focus on the one with Anktiva plus BCG, where it showed that in 82 patients at 12 months, there was about a 45% complete response rate, which is great. And speaking of cystectomy-free survival, as you had mentioned before, about that the patients who had responded at the 3-month mark to Anktiva, 93% had cystectomy-free survival at the 1-year mark. So some promising numbers there for sure.
I have it on my formulary here at UW. It's on my list of options that I present to patients. I think with BCG shortage, it's ongoing. I think that's one of the limitations of this drug is, I want to, save my BCG probably for other patients. So it doesn't really help with that scenario. And so I don't know. I think we'll see where it plays out. I mean, the efficacy, at 1 to 2 years looks, I would say, a little bit better than ZUSDURI. But once again, we don't have any real long-term data other than beyond, at 2 years. I believe they just released some 2-year follow-up data.
Yeah, and definitely what you're saying, it's still kind of in the way that it's been studied is given with BCG, so it doesn't really free us from some of the constraints that we have as an alternative in settings of a shortage.
Yeah, and then the kind of the newest FDA-approved drug, which I think is fascinating to think about, is this drug called Inlexo, or TAR 200, which is a pretzel, right? It's the pretzel. It goes in the bladder, and it's a really novel drug delivery system. Do you want to talk a little bit about that, Dr. Marchetti?
Yes, yes. So this is the gemcitabine pretzel that will slowly release gemcitabine into the bladder over a period of weeks. It is instilled through the bladder with a catheter, and it's dosed dissimilarly from the other medicines we've been talking about. So once every 3 weeks for 6 months, and then it's kind of replacement gets spaced out to once every 12 weeks or up to 24 months. And so in July of this year, it did receive the priority review. So it's still under FDA review, but an exciting new therapy. What are your thoughts on its efficacy from Sunrise?
Well, yeah, I mean, I think we were looking at similar efficacy to Anktiva, actually. I think it was in the sort of the 40 to 50%
Mm-hmm.
range of 12-month complete response. I don't, once again, we're going to need to see some, longer term efficacy data. But definitely, I would say an improvement from what we saw initially with Adstiladrin, and certainly an improvement from which a drug we haven't talked about, pembrolizumab,
Mm-hmm.
which I'm not sure I want to spend too much time on, anyways, because that's kind of gone down to the bottom of the list
Yeah.
in my mind. But
Yeah.
the concerns I have with this drug, in addition to some of the cost concerns, which we don't even know how much this drug's going to cost yet, is the pretzel has to be removed and replaced every 3 weeks, as you mentioned. And in urology offices that are already kind of swarmed with patients and overwhelmed and lacking of space, we're talking a lot of extra visits for these patients. So I think we'll see where this falls into play, but I think it's a lot of scopes and patients already that have sensitive bladders. You're adding in a lot of extra cystoscopies to retrieve these and then
Mm-hmm.
to deploy the device.
Mm-hmm.
But I do think the efficacy looks promising, which is a good
Good start.
goal. It's a start, and then the delivery mechanism is quite novel. Um, there's always been concerns about topical chemotherapy, like getting absorbed, or if you just put it in and then they pee it out after an hour, is it really what's going on the rest of the time, right? And with
Mm-hmm.
immunotherapy, you're at least modulating the immune system and sort of having some innate immunity to sort of have an ongoing durable response. So with this delivery system, it kind of overcomes that concern, which I like.
Mm-hmm.
But cost, and then I would say the burden on the health system, we have to consider those things.
Definitely, definitely. And similar to yourself, patients are coming from really far away,
Yeah.
a lot of times, particularly for in the setting of the shortage for non-muscle invasive treatments. And sometimes I feel like it's hard to sell patients on getting maintenance gemdosi once a month. They're like, I'm not coming if it snows. Like,
Right. Right.
okay. So
Right.
to try to get them to come even more frequently with the additional procedural kind of morbidity of scopes, etc. I think in practice may be a hard sell. And in the Sunrise trial, while only about 3% of patients had grade 3 or higher toxicity, about a third of them had to interrupt some of their treatment schedule due to some of the side effects of just the scopes and getting the pretzels, which again, if with how frequently patients are coming in, to have them drive all the way here and not be able to actually administer the therapy, I think would be a real um could potentially make it a tougher sell once we start using it in practice.
Yeah, those are all good points, and I think we've really covered a lot, Katie. I think this has
Hmm.
been a great discussion. I've enjoyed talking to you. I've learned a lot from you, and I think we've um, hopefully shed some light on the evolving landscape of non-muscle invasive bladder cancer for our patients. So I think we can sign off here, and thank you all for joining AUA News Inside Tract. Once again, I'm Kyle Richards.
Thank you all so much. This is Katie Marchetti.
And stay tuned next week as we talk with Dr. Niels Johnson and George Koch as part of our Global Perspective series as they talk about their experiences doing the AUA Exchange Scholar Program in India.
This has been an AUANews Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.